Good now. So this is a slice through the pelvis. This is the prostate in the middle here. At the front, this white area is the beginning of the bladder, and at the back, the black, and this area here is the rectum. So if we go up or down, there we go. This is a slice taken a little bit higher up through the pelvis. I'm hoping the screen has moved, has it? And you've got a bit more of the bladder visible now. You've got more white in a sort of a horseshoe shape. That's the very top of the prostate here. And these are the seminal vesicles at the back. So these blobby white things at the back here are the seminal vesicles. And you can see that part of the seminal vesicles are quite dark here in the central part. And that's because in this particular case, the prostate cancer is extending up and into the base of the seminal vesicles. This is a picture taken from the external beam radiotherapy planning software. So this is sort of conventional treatment, not brachytherapy. I'm just going to show this to give you some comparisons. And what you can see in the middle there, hopefully, are a variety of different coloured lines. And this is what we as the clinical oncology team do. We come along and we draw on the bit that we think needs to have treatment. So we've drawn some orange lines here in the centre, and then those orange lines are grown into these purple and pink lines, which become what we call the planning target volume. So the safety margin around the bit that we want to treat. Now, the reason for that is that we're concerned about the movement of the prostate every day, and we want to make sure we're treating any microscopic disease outside the prostate as well. So you give a safety margin. But the plan you end up with external beam radiotherapy involves beams coming in from multiple different directions. So you might have a beam from the front, a couple angled in from the front, a couple from the sides. And inevitably, the radiation, therefore, will go through a lot of normal structures as well. And that's part of the benefits and the gains that you get from brachytherapy. Because in brachytherapy, you're sticking the radioactive straight into the prostate. You're not having to come through the skin, through the muscle. I mean, you can see on this image how much there is to get through from the skin surface, through the fat here, through the muscle, through the bone, all the way down to the center, to the prostate. And this particular image is in the lower part of the pelvis where there's no bowel or bladder visible. So on to brachytherapy. Let's talk through the procedure of what we do and show you some graphic images that'll make your eyes water at 7 o'clock in the evening. Hopefully you got your gin and tonic at the ready. So there's a bit of preparation the day before the procedure is done, and that's basically to clear the bowel out as much as possible, because the planning of the procedure is done with an ultrasound probe up the back passage, pointing at the prostate gland. So we need the bowel to be completely empty. So you have a day off your food, just fluids, and a whole bunch of bowel medication to clear people out completely. And then on the morning of the treatment, people come to the admissions unit first thing in the morning. They meet myself or my counterpart, Dr. Nick Pota, who does the prostate brachytherapy with me. He and I do it for the patients in Sussex. And then we do the consent process and you meet the anaesthetist. And then you go around to the theatre room and go to sleep. So they have a spinal anaesthetic to put them to sleep, just like an epidural. And then they have a light general anaesthetic as well, because it's a relatively quick procedure, about 45 minutes procedure. So we don't want a deep anaesthetic because we want them to wake up and recover pretty quickly. And then when people are asleep, they get put into this undignified position where your legs are up and out the way into some stirrups. And the genitalia, the testicles and penis are taped up and out of the way. So you can reveal what's called the perineum, that area of skin between the prostate, between the testicles and the back passage. And over that perineum is placed a template with an ultrasound probe going into the back passage. That's what the template looks like. It's got, as you can see, numbers and letters as a grid system. And the images that we see on the ultrasound screen then tell us where we need to put the needles. And I enjoy saying this to the medical students as they can relate to this, but you basically then play battleships, because you've got an ultrasound image of the prostate in front of you and you've got a grid and you say C3 or B2 or A5. And we work together with the radiographers and the physicists in the theatre, and we put the needles into the prostate. This is a picture actually talking about the implant of seeds in this particular case, and this bottom right image is showing you some little black blobs, which are the radioactive seeds, which are connected by a little thread. That's not the procedure for the high dose rate brachytherapy, where what we're putting in are blind ending plastic tubes. And then they stay in that template, this template that you saw here, and they're locked into place by a clever locking device. The patient, then that template there is then stitched to the perineum, so that the patient then wakes up with about 20 plastic tubes through that template, stitched onto the perineum, and they wake up with a catheter in their bladder as well. So that's another image of how it's given with a bit more anatomy. So you've got the ultrasound probe there, you've got the template grid here on the skin, and you're putting in the implant catheters, as they call them here, or plastic tubes, straight through the skin and the base of the shaft of the penis here and into the prostate. In fact, the needles go through the prostate and out the other side a lot of the time into the bladder. And that's to make sure that we've got a safety margin at the end there, so that if the tubes then move during the day, there's a bit of extra safety area to make sure we cover the whole region. Then we do some planning scans in exactly the same way as we did when we were talking about external beam radiotherapy. So this is a CT scan now of the patient's prostate. And on this occasion, compared to the image I showed you before, you can see lots of white dots all the way through the prostate here. And these are the catheters, with a metal CT marker placed within the catheter. And you can see that they're nicely distributed, with about 4 at the front there, 3 at the side, another 2 or 3 at the side there, about 3 or 4 at the back, and about 4 in the middle. This area here at the front, which has been outlined and contoured, is the catheter. And the catheter will therefore give us an idea of where the urethra is. And the key organ that's going to get side effects and problems with brachytherapy is the urethra, is the pipe going through the prostate. So we need to know exactly where that is. But fortunately, the catheter shows up on the CT scan, so we can identify that very, very easily. These are some other images just showing you the layout in the anatomy. So this is an image taken straight through the body, as if you were cutting down through the patient straight down. And you can see the bladder here. You can see the tubes, or at least some of them, poking straight up and into the bladder. Lower down, you can see the dotted coloured lines, which are the outlines covering the prostate that we're going to treat. And then finally, this is an image as if you were doing a different orientated slice straight down the middle of someone, splitting them into the right and left rather than front and back. So splitting the patient right and left, this is an image straight through their centre, because you can see the spine at the back here. And you can see the rectum, which is marked at the back, and the bowel that goes up behind. And again, you can see all the tubes coming in through the skin into the prostate gland. You can also see quite nicely on this image the catheter, or at least some of it. So the catheter does this U-bend here, where it's coming in from the penis. It's going through the urethra, round up through the prostate and into the bladder. And then decency protected with a little blob over the relevant region here on the final image. So this is what it looks like when the patient finally gets to the cancer centre for the brachytherapy treatment. So they've woken up from their anaesthetic. They've had a CT scan and an MRI scan. And myself and the physics team have done all the voluming and planning together. So I draw on the area that needs treatment, and I draw on the urethra and the rectum to say that doesn't need treatment, thanks very much. And then the physics team come up with a plan about where the radioactive source needs to loiter in the prostate, in those plastic tubes, and for how long. And then when that plan is ready, the patient comes into the protected room, and these plastic cables here are connected to the tubes that were hanging out of the perineum, the area down in the just behind the genitalia. And the tubes, these cables here, are connected to a lead-lined box, and inside there is the radioactive source. And the radioactive source is on the end of a long cable, and that long cable then forces its way down through each of the cables into the plastic tube in the prostate, one after the other. And each time it goes into the prostate, it then loiters for a few seconds in different positions to emit the radiation in as accurate a way as possible. to deliver the dose of radiation deliberately straight into the prostate gland, but not into the bladder or to the back passage or anything else. And therefore you're avoiding an awful lot of normal structures by doing it this way. Once that procedure is finished, so the actual process of delivering the radiation with that wire going in and out takes about 20 minutes, half an hour maybe. So that's actually the shortest part of the day, but we're talking now about mid-afternoon, late afternoon, by the time the patient gets around to having this part of the treatment, after having come in at sort of 7:30 in the morning. So it's a long old day for both patient and staff. And then once that treatment is finished, the tubes can come out of the prostate. So about 15 or 20 tubes are pulled unceremoniously out of the prostate gland with a bit of gas and air, a bit of Entonox, and painkillers as required, because that can be probably the most uncomfortable part of the day, in fact, because the anaesthetic is starting to wear off, but it only lasts about 2 or 3 seconds. So most people squirm briefly and then relax because everything's done and the tubes are out. The urinary catheter is still in place, and at that point, when the plastic tubes are out of the prostate, we can see whether we've caused much in the way of bleeding into the bladder. And the urine, because the urine will change colour, and depending on whether it goes a light rosé or a dark claret or remains urine coloured, then dictates to us what we need to do, as in whether we can leave the catheter in for a bit and irrigate the patient. In other words, force some saline into the bladder to wash out any blood or clots, or whether in fact we can take the catheter straight out. The key thing there also is that once you've taken a catheter out, what you want to happen is for the patient to be able to wee themselves successfully. And they need to wee a couple of times to prove that the pipe is clear and that there's no clots blocking the way, so that then hopefully we can send the patient home. So the aim and the hope is that it's a day case treatment. We have had a number of people who stay in, but more recently, actually, the vast majority have gone home. That's partly probably also because we're just doing one case per week now. We're doing it every week as opposed to fortnightly, but we're doing one case each time. So, and it happens on a Thursday. So tomorrow morning I'll be in theatre sharpening the plastic tubes and getting ready for the next case. And as I say, over the last 3 to 4 months, every patient has gone home the same day. The key side effects are that the area which we've punctured with 15 or 20 tubes is inevitably going to become a bit battered and bruised, and it can become quite dark and discoloured due to all the little punctures that we cause. The prostate becomes a bit swollen because, as you'd expect when you shove a bunch of tubes into it, and if it swells, it can swell outwards, but it can also swell inwards. And by swelling inwards, it can narrow the pipe a little bit. And by narrowing the pipe, it can then affect weeing. It can then make people have a poorer stream and not go as easily, and sometimes go a bit more frequently at night. Now, that narrowing of the pipe is the cause of the blockage as well, if they can't wee successfully, and have to have the catheter back in. About 2 weeks after the brachytherapy is done is when people get their external beam radiotherapy treatment. So the vast majority of patients having high dose rate brachytherapy are having it in combination with external beam. So in other words, it's given as a boost to try and increase the dose to the prostate where the vast majority of the tumour is and the key components of the cancer are. But they also need the safety margin of treating around the outside the prostate, and possibly sometimes treating the pelvic lymph nodes as well, which is what happens with the external beam radiotherapy. The external beam radiotherapy usually starts a couple of weeks later and is somewhere between 3 and 4.5 weeks long. And then there are slightly different side effects, but there's a bit of an overlap with the external beam radiotherapy. So that includes things like a bit of loose bowels, a bit of diarrhea, and possibly some aggravation of the urinary symptoms again. So that, I think, was the end of the snapshot slideshow of the brachytherapy procedure. I have got 2 other presentations which we could or don't have to do. I'm going to be partly guided by Roger here, and I can see him on my little screen to the side of what I'm displaying, so you can nod or shake your head. So we could do some questions on the brachy, or I could do another quick presentation if that's helpful. Or do you want to unmute, Roger, and let me know what you think?
Yeah, it might be worth doing some quick questions on the brachy before going on to another.
No. If I stop sharing and then I go to participants, then I can see if people put their hand up, I think. So, and you have to electronically put your hand up because I can't see you in my screen because we've got too many people for the screen. And if people don't know how to do that, you go to the bottom of the screen, there's a little icon that says participants, which we're up to 55 now, I think. Mm-hmm. And you click on that, and on the bottom right, you'll see a column of names, and on the bottom right, you click raise hand. So Ray has raised his hand. Now, Ray, you're probably muted, so you'll also need to unmute yourself, and then you can speak.
Hi there. Interesting presentation you did. They're very informative. One question I have is, what happens with the radioactive material? Is it actually left inside the prostate, or is there no material left there at all?
No, nothing at all. So it's a blind ending plastic tube, and the radioactive wire, which is attached to a normal wire, is pushed into the prostate, to the tube, and then it comes straight back out again, and then it goes in the next tube, and then it comes out again, and then it goes in the next tube. And once it's done all of them, the wire goes straight back into that lead-lined box again, and is sealed away, so it's completely safe. And that's when the radiographers can come back in, and there's no radioactivity in the room at all. That source needs changing every few months because its radiation decays and you lose the radioactive, you lose the activity of the source. So every 3 or 4 months we have it changed, and then that can affect the time that it takes for each patient to receive their dose. But no, it disappears again. Nothing's left in the patient.
So you're not walking around partly radioactive for...
No, so that's the difference from the radioactive seeds, in fact. So the implant seeds do make people very slightly radioactive for a bit. The radioactivity falls off extremely quickly with the seeds. So by the time you get to the skin surface, the dose is very, very tiny. But patients who do have seeds put in are given certain bits of advice about avoiding pregnant mothers and babies and that kind of thing for a bit of time. Not very long, but they are a little bit radioactive for a while.
Thank you.
Okay, thank you. We've got Ron Linkins.
Yes, by coincidence, I am due to have high-dose brachytherapy on Monday and Tuesday next week up at Mount Vernon Hospital.
Okay.
And I'm told that he'll be doing a session on the Monday and also one on the Tuesday.
Okay.
So I'll have to sleep with the big plastic sort of thing stitched to me overnight. So
yeah. Okay. Yeah.
I'm comfortable. The history is I had external beam radiotherapy back in 2013.
Yeah, so this is a salvage treatment, an attempt to get rid of it.
Salvage radiotherapy.
Yeah.
I don't know how common that is, or how common it is to have two lots.
Are you part of a trial, or is this a...
No, I've been referred by my oncologist down here up to Mount Vernon under Professor Hoskin up there.
So I don't know whether he's doing it. Is this Peter? No, Peter Hoskin's not there anymore. Is it Roberto Alonzi and Peter Osler and that team?
No, Peter Hoskin, Professor Peter Hoskin.
Yeah. I thought he'd moved to Manchester. He's clearly
he's at Mount Vernon.
Still at Mount Vernon. Okay.
Yeah.
So he's doing a prospective data collection of patients who are getting salvage brachytherapy after they've got recurrence following previous external beam radiotherapy, which is exactly what you're getting. That what we call fractionated course, in other words, 2 treatments separated by a few hours, seems to be what they feel is a better way of delivering the treatment if you're doing it after someone's had external beam radiotherapy. So yeah, they'll be asking you lots of questions in the months and years to come about side effects and toxicity and that kind of thing as they build up a database of saying, yes, it's a safe thing to do after external beam radiotherapy, and yes, hopefully you've gone back into remission.
So this is part of a trial, is it?
I don't think it's a trial. I think it's just more of a prospective data collection, but you'll have to talk to Peter Hoskins about that. I'm sure he would explain it for you.
Okay, thank you.
Good luck.
Thank you.
Charles Kemp.
Yes, thank you for that. It was very interesting. I just want to check if I've really understood this. I've had the hormone treatment, I'm still on the hormone treatment, and I've had radiotherapy. I seem to have thought that brachytherapy is something you have before radiotherapy, or you have it instead of radiotherapy. So is this something that, depending on the circumstances, would apply to me, or have I gone past the time where I could have brachytherapy?
Well, just to make it really confusing, there are all of the options you've just described. So you can either have brachytherapy on its own, or you can have high dose rate brachytherapy followed by external beam radiotherapy, or you can have external beam radiotherapy followed by high dose rate brachytherapy, or you can just have external beam radiotherapy, as was described by the last gentleman, and then years down the line, if you get a recurrence, then you can have high dose rate brachytherapy as a treatment to try and salvage it. I think if a decision had been made that you were having hormone treatment and just external beam radiotherapy, then hopefully the decision is that that's sufficient treatment and you've gone into remission, and that's the end of it. So the choice of the treatments, we didn't really talk about the patient group that we do it for. The choice of the treatments depends really on the risk factors of the cancer at the time of diagnosis. And rather than talking about individual patients, I'll just give you a broad overview that in the patients where I showed you those MRI scans of the patient where it had gone up into the seminal vesicles, that's called a T3B tumour. So it's slightly more advanced than just being in the prostate. Also, the slightly higher grade cancers. So if it's a grade 8, 9 or 10, then that's a higher grade range. Then those are the patients which would often be thought about for the brachy boost. And then there's also the patients with a slightly higher PSA. So if the PSA is 30, 40, maybe even higher at the time of diagnosis, then that would also be a possible rationale for giving it. But there's also other factors you've got to think about when you're considering whether it's the right thing to do, and that is urinary symptoms, because it can aggravate urinary symptoms. And if people have got not insignificant symptoms already, then brachy may not be the best option for them. Also, if they've got other medical problems, other comorbidities, as we like to call them, which are going to make the anaesthetic a bit more challenging, or whether people are on blood thinning treatment, which is not quite so good if you're going to start sticking needles into them, then all of these things come into play. So there is a broad group that we do down in Sussex, which is the high-risk localised group. But again, they've got to have pretty few urinary symptoms and hopefully be otherwise pretty fit and well.
So in my case, probably then is, if everything stays okay at the end of this last year of hormone therapy, I'm okay. If something else happens, then brachytherapy might be a possibility.
Possibly. It would be very hard for me to comment on your individual.
Yeah, thank you. Thank you.
That's all right. So there are no other hands up at the moment that I can see. Roger, have you had a presentation at any stage relatively recently about the Radicals trial?
No, we've not had anything on Radicals. No.
Can I show you some slides on Radicals then? Because I think it's probably more interesting and relevant than the other presentation that I was thinking about.
Yep. Okay.
So I'll do that one if that's okay, if I've got time.
Yep.
Now let's see if I can get it working again. So let's get rid of the participants in the nicest possible way. Share screen. What can you see there? I'm still relying on Cliff or Roger. Can you see it?
Yeah, that's the Radicals screen. We haven't got the full screen.
What about now?
That's it. That's full screen now.
Perfect. Okay. So these were slides forwarded to me by Chris Parker, who I think is also a member of the Scientific Advisory Committee for your Picasso group, isn't he?
Yes, he is. Yeah.
He very kindly shared these slides with me, and I'm not going to show all of them, but I'm going to skip through to show you some of the interesting ones, because this has been a really important trial in terms of how we look after patients when they have had an operation for their prostate cancer. So now we're talking about a slightly different group, and just to make it really confusing again for Charles and everyone else, there are so many different options for people right at the beginning when they're first diagnosed. And one of the options is that they get a surgical removal of the prostate rather than brachytherapy or external beam or anything else. But the patient group that we're looking at in this trial are patients who have had a radical prostatectomy. They've had a surgical removal of their prostate gland. And the trial was trying to answer the question, do you need to give radiotherapy straight after you've done an operation to try to reduce the risk of the cancer coming back if that patient had some, inverted commas, high-risk features? Or can you watch them really, really carefully, watch their PSA, and then give them what we would call salvage radiotherapy if the PSA starts to rise? Historically, there were two other trials which had tried to answer this question, but they were very, very conflicting, and they were much, much smaller trials than Radicals ended up being. So Chris et al. Thought, well, let's do a really big trial and try and answer this question for good and proper, but also in a more modern era when we have super sensitive PSA assays. So we've got blood tests where you can pick up a PSA at 0.01 or 0.02, so at very, very low levels. And so the trial was, I'm trying to get rid of, there we go, that's better. I'm trying to get rid of my face. I can only see Roger now, that's lovely. Roger and the full screen. So this is the trial design. So these are patients on the left. So they had a radical prostatectomy, and straight after their prostatectomy, we want their PSA to have gone under 0.2. They were entered into the trial any time between 4 or 22 weeks after the operation. And to be eligible for the trial, they needed to have had one or more of these features on the left here. So either a T3 or T4 tumour, which means it's poking outside the capsule of the gland, or it's got to be a Gleason 7 cancer or above. So Gleason 6 on its own was not an eligibility. If their PSA before their operation was greater than 10, then they were potentially eligible. Or if they had a positive margin of excision, in other words, when the surgeon did their operation and they put their knife around the tumour and gave it to the pathologist, if the pathologist said the tumour went right up to where you put the knife, then that's referred to as a positive margin. And there's a concern, obviously, that there might be some cells left behind. And then the randomization in the trial, so they randomly allocated patients to either radiotherapy straight away, known as adjuvant radiotherapy, or they were randomized to what we call salvage radiotherapy. So that's radiotherapy given if they had PSA failure. And PSA failure was defined as a PSA of greater than 0.1, and then it must have risen on 2 occasions, or it rose 3 times in a row, and it could be of any value at all. So it could have even been 0.05, 0.07, 0.09. So super low levels here, but 3 rises in a row, and then that constitutes a, inverted commas, PSA failure. The outcomes of the trial were to look at a number of different things, but in the presentation that they gave, they didn't have data on overall survival. So we were looking at PSA results and freedom from progression, which is the phrase that's used frequently in this context. They also looked at freedom from starting hormone therapy, which is often an indication that the clinician looking after that patient has concerns that there is recurrence. Now, I'm going to skip down through some of the statistics, but the definition of biochemical relapse after they've had their treatment, so in other words, in the adjuvant group, if they had their radiotherapy up front, if their PSA after that ever got to a value of 0.4, then that was defined as a recurrence. If the PSA was greater than 2 for either group, that was also defined as a biochemical recurrence. Patients from all over the world, mostly in the UK. This is the baseline characteristics table that they always give, which basically shows that because it's a randomized trial, the facts and figures about the patient's cancers were basically identical, because you've got 700 patients in each group, so a very large trial, average age 65, PSA at diagnosis almost exactly the same, 7.88, that is the median. And then all the features about the Gleason score, the T stage, the margin positivity, they're all almost identical in both groups, which is what you get if you've got very large numbers of patients going into a truly randomized trial. I'm going to skip down now to the take-home message. So this is biochemical relapse leading right out to 8 years. So this is the number of patients who've had a biochemical recurrence. In other words, the PSA has gone up to a level which we have then labelled it as calling it a biochemical relapse. And it's going right out to 8 years from going into the trial. And as you can see in that time frame, if I can wiggle my mouse appropriately, this number of people here have had a recurrence. But this number, so over 80%, are still in remission. So 80% of the patients who went into this trial were still in remission 8 years on, and that's whether or not they got the radiotherapy straight away or whether they got radiotherapy when the PSA started to rise. And that's the key message. Basically, there's no difference in those two curves. And then if you start looking at the clever statistics, you look at this thing called the hazard ratio. And if the hazard ratio crosses 1, then it means there's no difference in the two groups. And this is going from 0.8 to 1.4. So it's plumb over 1, which means there's no statistically significant difference between these two groups. And the same is true for this another measurement, which was freedom from non-protocol hormonal therapy, which is, in other words, where I said that the patients were started on hormonal treatment by their clinician because they had concerns about recurrence. And basically, the two lines overlap again, and that means there's no difference at all. So basically, this is good news in terms of the fact that we think it is entirely safe to not give radiotherapy straight away after an operation, even if they have one or two of the high risk features, because the salvage radiotherapy option is just as good as giving them radiotherapy up front. And what you're also managing to do then is to avoid over giving radiotherapy, because although I'm obviously a radiotherapy doctor and I recommend it and give it to an awful lot of people, if you don't have to have it, then that's a good thing. And we don't want to give it to people who are not going to get a recurrence. And in that group of patients who had high-risk features at the time of diagnosis, some of them will never get a recurrence, but you just don't know which ones at the start. So if we can avoid giving them that treatment, because we've now proven that we can give salvage treatment, which is just as effective, then that's a much better option. So I would say, I'm just going to skip down. Yeah, I don't think there's any other bits on that slide that I wanted to share, but I would say that that has been a practice-changing paper, in as much as it's allowed us to stop giving adjuvant radiotherapy straight after surgery to patients, even if we felt that there were one or two features which made us slightly anxious that we needed belt and braces treatment. Okay, I'm going to pause again so I can have a swig of water. And again, well, let's do the same thing about the questions if you want. So if you go back to participants and put your hand up and then unmute when I say your name. So David Griffiths. I can't hear you, David, if you are.
No, I'm here. I'm just struggling to find my unmute button. Thank you, Angus, for that. Just a quick, I'd never heard of this as an option before. I had radical prostatectomy back in 2013, was diagnosed with metastases in April this year. But does this suggest that possibly I might be a candidate for radiotherapy now?
So it depends on what they're referring to as metastases, because if you've been unlucky enough that it's come back and it's spread to other places around the body, then radiotherapy to the pelvis is not going to be beneficial. The radiotherapy to the pelvis is for the patients where we think that the reason that their PSA has risen is because the recurrence is within the pelvis, in the area which we call the prostate bed. So going back to those CT scan slices I showed earlier on, it would be that sort of region that we would give the radiotherapy to. But
mine is in lymph nodes in the prostate bed.
Yeah, but if someone gets a recurrence which is out of that field or in the lymph nodes higher up outside the pelvis, or even further afield around the body, then that radiotherapy wouldn't be beneficial.
Okay, but as far as I understand it, I have lymph nodes that are active in the prostate bed and also something in my spine at C3. It sounds like that one wouldn't be, but the ones in the pelvic area might be.
Yeah, so then it's a question, I'm not sure where you're being looked after or treated, but then it would be a question of whether or not the one in the spine could have some radiotherapy as well as treatment to the pelvis, or whether there was a consensus that unfortunately there's too much evidence of disease outside the pelvis to render a long course of treatment through the pelvis not being helpful and potentially side effects.
there has been discussion of having the one in the spine having radiotherapy, but not of the others. So,
Okay.
anyway,
Okay.
I'm at Brighton and Sussex. So.
Well, it might be worth asking that question.
Yeah.
So you can, so you could have we're branching off onto a different topic here, which is what's called oligometastatic disease. So oligometastatic disease refers to disease which is secondary. In other words, it's not local anymore. It's secondary to distant places, but there aren't very many of them, or hopefully there's just one or two. And if that's the case, then there is increasing evidence that another form of treatment, such as stereotactic radiotherapy or high-dose radiotherapy of some form to that distant secondary, would be of benefit. And as I've just demonstrated, we know that radiotherapy to the pelvis is of benefit if people get recurrence within their pelvis.
Sure. No, thank you. That's really helpful and heartening. Thank you. I'll follow that up.
Okay.
Robin's got his hand up.
Has he? It's not appearing on my chart.
But his physical hand up.
Oh, a physical hand. I can't see physical hands. Yeah, fine. Thank you for being the extra chairman, Cliff. Robin.
Yes, I had brachytherapy in 2013 up at Guildford, and they did that for me because they couldn't get to have radiotherapy. They couldn't get my bladder pushed out of the way, and they said they would it would damage it. So I had the brachytherapy. And my PSA ever since has been 0.01.
Great. Yes, you've brought up another interesting fact. So I was talking about the group that we treat down in Sussex, mainly being the ones with high risk disease, where we're giving them a boost to the prostate. But actually, there have been a few cases where we've looked at their planning scan. They were going to just have external beam radiotherapy, and they've had their planning scan done, but it's demonstrated that just because of their anatomy being slightly different, a lot of small bowel has dropped right down behind the bladder on top of the prostate. Now, small bowel doesn't cope very well with radiation. Bladder copes fine, large bowel copes okay. But if the small bowel is dropping down and very close to the prostate, it is going to get a meaningful dose during external beam. And that makes us a bit anxious. So for those patients, on a couple of occasions, we've then converted them, even if they weren't particularly high risk, we've converted them to giving a much, much lower dose with external beam, but we've boosted the dose to the prostate with the brachy because of this feature that the dose from the brachy is very confined. It doesn't then spread outside the prostate to the bowel. So it's a good way of minimizing the dose externally. So thanks for that.
I feel that I've been very fortunate.
Thank you for that. Stephen Tutton's got an electronic hand up, and I'm sure someone will tell me if there are any more physical hands. Stephen.
Thank you for the presentation. It's very informative. I had testicular cancer 36 years ago and had 18 sessions of radiotherapy. Now there's a doubt as to whether I've now got prostate cancer. I've had on hormone therapy and chemotherapy. Would there be any reason not to have radiotherapy in view of the previous radiotherapy?
So you're not under my care, are you?
Sorry?
You're not under my care?
No. Kiwi.
There is I have got a gentleman in a very similar position to you, in fact, who had radiotherapy for testicular cancer 20, 30 years ago.
Yeah.
And for exactly that reason, we have elected to go down the combination external beam and brachytherapy route, because we wanted to reduce the dose of the external beam radiotherapy because of the concern that the previous radiation from the testicular cancer combined with the up-to-date radiotherapy was going to end up with too much bowel damage. So I think it's a very real question that you should ask. Obviously, I can't comment about the extent of your disease, the grade, the PSA, what's been found on imaging, and that's the thing you need to discuss with your clinician.
Yeah, I had two Mets, one on my arm, one T5, which halfway through the chemo I had an MRI, and they had disappeared. I know that's not a. Well, they're smaller.
That's great. Well, if they were definite secondaries,
yeah,
and they are responding, then that's clearly good news. Now, whether you go down the route of this treatment of oligometastatic disease that I referred to 2 questions ago,
yes,
which is it possible for someone to give some high-dose treatment to the 2 lesions in the bone, the arm and the spine, as well as some radiotherapy to the pelvis? I don't know. You're then talking about more and more and more radiation, so you just have to be a little bit cautious about how much you can give. I mean, we certainly think that radiotherapy helps a lot, and I'm sure many of you have heard about the Stampede clinical trial. If I can digress again briefly before we go on to John Kempshall. The Stampede trial has looked at multiple different options of drug treatments and combination treatments for people with advanced disease at the time of presentation, and probably the reason you're getting chemotherapy at the moment, because of the results of that trial. One of the newest versions of the Stampede trial is going to include an arm looking at radiotherapy to oligometastatic disease. So if people have got 1 or 2, maybe 3 isolated spots of secondaries somewhere else around the body, then the plan potentially is to give radiation to all of them and to the prostate, as well as the hormones, as well as the chemo, as well as blah, blah, blah. So yeah, it's a real question that should be asked, I think.
Okay, thank you for your answer. Thank you.
John Kempshall.
Dr. Angus, can you hear me?
I can.
Very interesting Zoom, thank you. I had a radical prostatectomy 12 years ago, and I was left with a positive margin. I've since had metastasis into my lymph nodes in my pelvis, where there are apparently 5 tumors, 1 large and 4 small. I've investigated a thing called cyberknife, which I don't think you've mentioned. And also, I'm wondering whether I should investigate immunotherapy. Would you care to comment?
So if this is a new diagnosis of relapse in the lymph nodes in the pelvis, then my recommendation would probably be that you have hormonal treatment plus radiotherapy to the pelvis, including the lymph nodes, once the lymph nodes have shrunk down a bit with some hormone treatment. Cyberknife, the advantages of cyberknife are when you've got a small discrete lesion on its own. If you're treating a range of lymph nodes or a lymph node field, it wouldn't be of any benefit, and you'd need intensity modulated radiotherapy. So I don't think cyberknife would be of help. As regards immunotherapy, there's absolutely no evidence of the benefit of immunotherapy in any stage of prostate cancer yet. So no, I wouldn't be recommending that if you were under my care. Now, that's not to say it shouldn't be looked at in a trial setting, and increasingly it is. But there are many more proven treatments in prostate cancer which are more advantageous.
I had salvage radiotherapy straight after the radical. So I can't have any more radiotherapy down there.
Okay.
But I'm being kept going very well on enzalutamide.
Okay.
I just wondered if there was any other scope. Presumably I shall move on to chemotherapy as and when necessary.
Yeah, so there's a few other options there for you, including chemotherapy and including some of the novel treatments like the PARP inhibitor, which we haven't had a chance to talk about tonight. But I certainly don't think immunotherapy is going to be the option currently. And it sounds like you're doing very well on the combination of drugs that you're on, so that's good news.
Indeed so, yes. Thank you very much.
No problem. Any other physical hands? I can't see any other.
I can't see any.
Okay. So is it supper time then?
I think so.
Oh, Roger's got a hand up.
Yep.
He's allowed to ask a question.
Yeah, I'm wondering where the hormone therapy fits in with radiotherapy, because I in a lot of cases now I've heard that radiotherapy patients are also getting a bout of hormone therapy.
Talking about in the salvage setting after surgery, aren't you?
Is that in only for salvage or just for straight?
I wasn't sure which group you were asking about, because there are so many groups who get radiotherapy, obviously. So,
right, regular people that are going for radiotherapy.
Yeah, so I'd say still the vast majority of people who are getting external beam radiotherapy or external beam radiotherapy and brachytherapy combined would all get hormonal therapy. The sort of low intermediate risk group who are getting implant brachytherapy as a monotherapy, as their only treatment, they're often so low risk that they don't need it. But we don't do those down in Sussex. They go off to Guildford, as you probably know. So the groups that we treat with brachytherapy, they all get hormonal therapy, but that's partly also because they're mostly higher risk groups who definitely benefit from hormonal treatment. What I thought you were also hinting at was the question about the role of hormonal treatment in the salvage setting. So, and this is a bit more controversial and interesting. So I've described how salvage radiotherapy is just as good as adjuvant radiotherapy, and therefore we don't need to give adjuvant radiotherapy anymore. And then there is some data to say that if you give hormone treatment at the time of salvage radiotherapy to the prostate bed, that can be beneficial for patients. The problem is they are slightly old trials, and the PSA, they let the PSA get to quite a high level before they went into the trial, much, much higher than the level that we now say, oh, it's time for you to have some radiotherapy to your prostate bed. And so we don't routinely give hormone treatment to everyone who gets salvage radiotherapy, I suppose is my summary of that. Right. But if there are some people who, for whatever reason, they've got lost to follow up, or they've had a very rapidly rising PSA many years after surgery, and the PSA is 2 or 3 or 5 or something, then I would give hormone treatment as well as radiation. If it's only 0.2, 0.3, then I don't. I just give the radiotherapy.
Would there be a reason to give hormone therapy if the prostate was particularly enlarged? Because obviously the hormone therapy shrinks the prostate.
It does a bit. It's never, and it would have to be GnRH analog hormonal therapy, not bicalutamide or an anti-androgen. So yes, that has been done in some cases. I've never been overly convinced it does it dramatically to the actual prostate. It shrinks the lymph nodes really nicely if they're affected. But if someone's got a really big chunky prostate, they're probably still going to have quite a big chunky prostate even after 6 months of hormone treatment.
Right.
But it's worth a go.
Yep. Thanks.
We've got another hand up with Derek Pilling.
Okay. Derek? You're muted still, Derek, if you can reach the mute button. Well,
sorry, I had radiotherapy in 2004, and 5 years later had HIFU treatment, which is a whole blast of HIFU, not the ones they do now. And that recurred in 2013. And that was specific to directly HIFU treatment at where they knew the cancer was. And since then, after the HIFU treatment, I was about 0.01. And then gradually, over the last 5, 6 years, 7 years nearly now, it's gotten up to 0.7. It's been going up gradually, 0.1, 0.2, 0.01, 0.02, then right the way through some now 0.7. Does that fit into your biochemical relapse that you're talking about?
Yeah, it probably does. The problem is you're probably struggling for local treatments to the prostate again now. What would probably be done is a repeat scan of some description when the PSA reaches 1.0. Yeah. Have they suggested you can have any more HIFU or not?
They did at one time say I could, but they've been having second thoughts about that.
Okay.
My prostate is actually only down to 2.5 centimeters cubed. It's very small now with all the treatment.
And you run the risk that repeated HIFU treatments can leave not inconsiderable side effects with sort of...
Yeah, that's right.
Healing. And
it's not metastasized, thank God.
No. So I think with a very, very slow rising PSA, we would probably sit tight and do nothing. If it gets to 1 or above, you might start exploring the possibility of some fancy new scan of some description, the best one being the PSMA PET scan, if you can access it. And if that shows nothing, I'd still sit tight and just watch it. And eventually you might get to a point where we go, okay, a short course of hormonal therapy will bring this right back under control, even if it's just 3 or 4 months, switch it all off again, and then you start...
Well, I'm concerned with hormonal therapy because it affects my voice. I had a tablet before the radiotherapy, 150 gram, can't be cuddies?
Glutamide, probably.
Yeah. It was just a small tablet that I had for 6 months, which reduced the size of the prostate. So that was it in actual fact.
Well, it certainly sounds as though nothing needs to happen quickly at the moment if it's a very slow rise.
Well, thank you for that. I said it would be quick.
Oh, a couple more have appeared. Tony Ball.
Yes, Angus, please. I'm just picking up on you mentioned PSMA imaging a moment ago.
Yep.
And you said difficulty in accessing it. What's the likelihood of that becoming more available through the NHS in our region? I believe it's just up in London on a trial at the moment.
Yeah, I honestly don't know the answer to that question in terms of likelihood, percentage chance over the next 6 months or year. It's certainly something that the nuclear medicine team are working on hard to try and access, but I can't tell you when we're going to get it much more freely available. We do have locally choline PET scans, which are also extremely good. And we are sending a lot of patients for choline PET scans at the moment. And we've got a very quick service in the PET scanning department down in Brighton for that.
Yeah, I had that about 3 years ago at the university.
Yeah.
Falmer, isn't it?
Yeah.
Is it the machinery that, is it just a question of the isotope then, or is it the same equipment that delivers it?
It's the same. It's produced in a different way. So my understanding it's the creation of the isotope which is the issue. I think the scanning is the same once you've had the injection.
Right. Thank you.
Alan Taylor, Isle of Wight, as opposed to all the other Alan Taylors.
Okay, can you hear me?
Yeah.
Okay, good. Right. So I had my prostate removed in 2011, 2012. I had salvaging radiotherapy. 2016 it returned, and I was put on to hormone treatment for 2 years, injections, taken off of that after 2 years, and put on to bicalutamide for 2 years. And now I have a rising PSA and being put back onto bicalutamide, but I now have pelvic pains, which have put me. I've been in for an MRI, but there's a delay in what's happening with that because there's an increasing amount of COVID on the Isle of Wight. What could be the next stage?
Well, you need those scans done, don't you? You need to find out why you're getting the pains to find out whether there is any further recurrence. If you're just on bicalutamide at the moment and not on hormonal injections, and you do have recurrence, then you're probably going to need to go back onto the hormone injections to switch off testosterone production. And then I don't want to predict one way or the other, but there are a number of different options if recurrence is found. Particularly actually since COVID's been around, we're allowed to prescribe enzalutamide in combination with GnRH analog injections for newly diagnosed metastatic cases. So if you were unfortunate that secondary disease was found, then in addition to going on to the GnRH, it would be going on to enzalutamide as well, probably.
So enzalutamide is better than abiraterone?
It's the one that we can access, and I think probably it is better. It's easier, it's better tolerated, and you don't have to take steroids with it. And there are slightly fewer side effects. I think they're probably equivalent in their effect, if we're completely honest.
Right, thank you very much.
Okay.
That exhausted the questions. Nobody else?
There.
Okay. Well,
lovely. Thanks, Roger.
That's great, Angus. I think people have got a lot out of that, and thanks for taking the questions as well, because they've all been very interesting, and hopefully helpful to a lot of people.
Yeah, I hope so. Yeah, no problem at all.
Thank you very much for your time, for taking part. Yeah, everyone can give you a round of applause. Yeah, if you want to unmute yourselves. You muted me again.
Don't be shy.
Thank you very much.
I forgot, but we obviously, there weren't just Picasso members on this Zoom. There were members from the Isle of Wight group, as you obviously gathered, and there were a few members from the Mid Sussex group as well. So you've been talking to 3 different support groups there. Okay, I think you're still you're muted now, Angus.
Oh yes, sorry.
Okay.
So I was just saying the wonders of modern technology. We can do these broader and broader regions, can't we?
Well, this is it. I think we'll be doing more of these Zooms next year as well, because it doesn't matter where people are. The geography can be spread far and wide, so it gets to more people. And we've had a good number on the Zoom tonight. So I think we will be continuing the Zoom meetings even once we're out of this COVID situation.
Good stuff. Well, thanks very much, everyone, and stay well and free of infection.
Thank you.
Thank you very much.
Thank you very much. Thank you very much. Bye.
Bye.
Bye-bye. Thank you.
Okay, thanks everybody for coming on. Hopefully everyone have a good Christmas. Now we're allowed 3 different families involved. And we'll see you all again in the new year.
Thank you, Roger.
Thank
you very much. Thank you. Yes, thank you, everyone.
Thank you for the invite, Roger.
Thank you, Cliff.
Bye.
Thank you, Cliff.
Thanks, Cliff.
Yeah, thank you.
Ooh, the numbers are going down. Right. Yeah. Bye, everybody.
Bye.
I'll leave now.
Right.
Right, we're nearly there. Thanks, Cliff, for doing that. Did you manage to get it recorded?
Yes.
Yep. I'll see what.
I'll check it out later and see.
Check it out. Yeah, let me know.
Yeah. So I can end the meeting, but I'll see when everyone else is shut down. Okay.
Yeah. Good. Okay. Be in touch.
Yeah. Bye.
Bye.